Our next speaker is Richard Lewis, MD. Dr. Lewis is a professor of neurology and the director of EMG Laboratory and co-director of Neuromuscular Clinic at Cedars-Sinai. Dr. Lewis is board certified in neurology, electrodiagnosis, and psychiatric medicine. Sounds like a good guy to know. He obtained his medical degree at the Medical College of Virginia in Richmond. He performed a rotating internship at Hartford Hospital in Connecticut and a residency in neurology at the hospital of the University of Philadelphia in Pennsylvania, as well as a fellowship in electromyography at Pennsylvania Hospital in Philadelphia. And knowing that I am completely technologically inadept, Chris is going to help me put things back together here. Dr. Lewis was also previously the director of the Inflammatory Neuropathy Center of Excellence. So Dr. Lewis will be talking with us with a presentation entitled Understanding a Neurologist's Approach to the Diagnosis and Treatment of Peripheral Neuropathy. Dr. Lewis.
I think you're good.
Well, thank you very much, and it's a delight to be here. I don't know how many of you were here a couple years ago, because you may hear a little bit of the same thing. And I think this will be a little bit of a repeat of what Perry talked about, but hopefully an extension. So out of curiosity, how many of you know the cause of your neuropathy? So you have how many of those causes are idiopathic? Okay. So idiopathic, when we're talking about a smart person making something simple, I'll speak as a stupid person who will try to make things also, who only knows things simplistically. But idiopathic, in some respects, means that your doctors are idiots and they don't really know the answer. Now, in fairness, we don't have the answers. And it's not just your doctor, it's all the medical science. We still don't come up with the answer in a lot of patients. So we work hard to find it. And our first job is really to find, we really want to find something we can treat. And so if we can find a specific cause, say CIDP or Poems syndrome, there are treatments for those. And we can actually control the disease and sometimes even cure the disease. And when we have that, that's great. We feel good, you feel good. But that doesn't happen all the time. In fact, it's the minority of times. And then we have to deal, if we can't come up with something we can fix or cure, then we have to come up with treatments that help you live your life as best you can live it, which means treating pain, treating problems with walking. How can we make you walk better? How can you do the things that you want to do in your lives within reason? Someone with neuropathy who says, I want to climb Mount Everest, I might say that may not be a reasonable goal. But if they want to live their life doing other things, and including hiking, that may be something we can talk about. But it may mean wearing a brace. It may mean using a walking stick when you need to hike because it's irregular ground and it's harder to walk. So sometimes we have to use adaptive aids to kind of help people live their lives fully. So what we're going to talk about a little bit is what Dr. Shea talked about. We're going to talk about this history and exam, maybe go in a little bit more detail. And I'm going to spend a little bit of time saying that we sometimes ask you questions that why the hell are you asking me this question? And sometimes I ask, why are they answering that question in the way they're answering it? Because we don't always speak the same language. And I will talk about some treatable things, and we'll talk about some factors that go into the decisions on how we treat patients. So first issue is the history, and as Dr. Shea said, he talked about maybe 50% or 70%. sometimes we talk about the history is about 90% of the information we need to develop a diagnostic plan, and the exam and all the rest of it is just kind of the icing on the cake to understand it. So as Dr. Shea mentioned, we need to know the chronicity of this. Is this acute? Is it chronic? Is it subacute? When I ask the question, the usual response is, well, it became severe. When did it start, I'll ask, and the answer is usually, well, it got most severe 6 months ago. Well, I'm glad I understand that, but when did it start? And so, because when it starts tells us a lot. If it really started 6 months ago and you're really having a lot of trouble now, that puts us in the subacute phase. If it happened 10 years ago, but it really only gave you a lot of trouble now, that's a much more chronic disorder. So we need to understand really when it starts, not just when it got bad. How has it changed? Whether it's progressive. When I talk about monophasic, Guillain-Barré syndrome, for instance, this subacute or acute neuropathy that frequently begins a few days or a week or two after you've had some kind of infectious illness, whether it be a viral infection or diarrhea, people will then start getting numb and weak. And as you may know, people can become completely paralyzed and on ventilators from that in a matter of weeks. And that is a monophasic illness in the sense that from the beginning to the time you're at your worst is usually a 2 to 3 week process. And after that, it takes time, but many patients, and most patients, get significantly better, although not always completely. And we do have treatments to kind of speed up the process. So that's what I'm calling a monophasic illness. Anyone here had Guillain-Barré syndrome? Am I telling your story correctly? Oh, good. A relapsing disorder, I have the illness, I get better, seem to do okay for a while, and then it comes back again. So that would be what we call relapsing. So then Dr. Shea mentioned symmetry, and is it distal, just in the beginning in the toes and creeping up the legs over time? And so in 3 years, it's now at your ankles, and in 10 years, it's now at your knees and starting to get in your fingertips. So that would be kind of what we call length-dependent neuropathy. So all these things are what we need to know to get come up with the right diagnosis. So the symptoms, again, Dr. Shea talked about numbness, weakness, pain, and these autonomic features that Dr. Shea did such a nice job talking about. So some of you in the audience, not many of you, are old enough to have seen this movie. I don't know, I guess it's on Netflix, but failure to communicate. So, which had to do with the prisoners and the guards, but doctors and patients, we don't always speak the same language. So when patients tell me they're numb, a significant portion of the time what they're really talking about is their weakness more than their numbness. And so I'll say, what do you mean by your numbness? And they'll look at me like I'm crazy. Numb is numb. Pain is pain. What kind of pain do you have? I have bad pain. I understand. But there's, is your pain burning, tingling, which is neuropathic pain, or is it that if you're aching and your joints hurt, which is more what we call nociceptive pain, but not nerve pain? So we really want to understand numbness to us means there's something wrong in your sensory system. I don't feel things right. Things, when someone touches me lightly, like my bed sheets touch my toes, it hurts. A sensation that should be comfortable is uncomfortable. So that's a sensory symptom, and we kind of put it in the numbness category, which is not really correct because it's not numb, it's pain, but it's all part of this sensory phenomena that we talk about. But numbness is not weakness. So if you're not able to move your toes, now if you're not moving because they hurt, that's one thing, but if you really can't move them because you're weak, that's not numbness. The other issue is I've impressed, and I understand this, that when you come to me, you want to impress me about how terrible this is. And I understand you're not here to see me because life is hunky-dory and everything's wonderful. You're here because this is really bothering you. So I understand that, but what we really want to do is understand the nature of it, not only just that you're really uncomfortable. The other thing is you want relief now, and to some extent you want cure. Get rid of this for me, doc. And unfortunately, the doc on the other side knows, well, I'd love to do that, but that doesn't usually happen. The best I can do is control this. And so we need to come up with reasonable expectations for both of us. So it's important for you to kind of be very upfront talking to your doctors about what your expectations are, what your concerns are. So one of the things I learned a long time ago, that when patients come to me with neuropathy, many people, their first fear, their major fear is, I'm going to end up in a wheelchair. I'm going to be paralyzed from this. From my numb toes, somehow my rest of my body is going to collapse and I'm going to be in a wheelchair. It's an understandable concern, but sometimes the doc doesn't really think about it that way. So you need to say, let them know what your fears are. And I ask, what are you most worried about? And that's something that, and sometimes the best thing that comes out of our meeting is they come away knowing they're not going to be in a wheelchair. They're going to be able to walk the rest of their life. And so that's an important issue. Most people with neuropathy are able to walk the rest of their life. They may need a cane. They may even need a brace. And remind me to talk about bracing a little bit before I finish. But they're going to walk, and you're going to be able to do much of what you want to do in your life. There's a whole bunch of things related to aids. Patients that I see, when people have foot drops, braces or ankle foot orthoses is what they're technically called, can help secure your ankle so you can walk more securely, you won't trip over your toes, and you can do a lot of what you couldn't do before. The emotional, psychological aspect of getting an aid or an adaptive aid or using a cane is, I'm giving into my disease is taking over, I'm getting worse and I don't want to think about that, and I don't want people to see me in this. And so you need to work with your docs to kind of work through this. The other thing about these things is people say, I go in a brace, it's going to make me worse. That doesn't happen. So it really can be very helpful to you to take advantage of what's out there to make your lives better and more fulfilling. So some other communication mismatches, we talked about it. Cure versus control, stopping the pain versus controlling the pain. The other part of it is you want the worst parts of your disease to go away first. And we know that things don't work that way. Things work that the things that are least affected get better first, and the things that are worser get better later. Worse is one of my favorite words, even though it's not a word. But so whenever you do anything, and this isn't just for neuropathy, this is for any disorder you have, you and your docs both have to be on the same wavelength about what your expectation should be, both in the short term and the long term. So when I give patients corticosteroids for CIDP or IVIG for CIDP, they need to know that in the first month or two, they're not going to jump up and have everything's going to be perfect. It's going to take a little time. And the first things that can get better are going to be the things that are mildly weak. Maybe their shoulders were a little weak and maybe they get better first. But that tells me, one, the treatment's working and that we should persist. And two, when they recognize it, it gives them more hope that the treatment will continue to work for them. The other big communication mismatch is what is weakness and what is fatigue. And it's a real struggle for me to get my understanding of it and my patient's understanding to be the same. When I talk about weakness, I'm talking about my foot drops as soon as I start walking, or I can't get up from a chair. And when I examine them, I press on whatever limb I'm pressing on, and it's weak from the get-go. Fatigue is, I walk a while and I get tired. And then the question is, what do you mean by fatigue? Is it sleepiness? Is it just generalized, I'm exhausted? Cancer fatigue is a very common phenomena. And what is it? It's just a feeling of total body exhaustion that's very hard to describe as a patient, and actually for us as doctors to understand. But when we talk about weakness, we're really talking about, are your muscles able to work? And fatigue is an important issue, but it may not have the same connotation in terms of diagnosis. Other questions that we talk about, the family history we mentioned before. We often ask about whether there are any funny feet in your family, because that high-arched, hammered toes is a characteristic of inherited neuropathies. And we frequently ask, how were you as an athlete as a kid? Could you run? Were you the slowest in your class? Not to kind of hit on you, but just trying to understand, maybe this neuropathy was there before and you didn't think about it or chose not to think about it. Medications, big potential cause of symptoms. And unfortunately, if you look at the web, virtually every medicine you're on, someone's going to say numbness is going to be in there. Someone's going to say tingling is going to be there. Whether that's actually due to neuropathy or not is unclear. And you have to understand when the medications go on the market, and they've had clinical trials proving that the medicine works, whether it's for heart disease or antibiotics, every symptom that the patients have in the trial are recorded and are called adverse events. So you have a cold when you're taking a heart medicine, that's an adverse event. And if there are a bunch of them, then they are forced to kind of put on their marketing that these things can happen. It doesn't mean that these things necessarily cause the disease. So you just need to be a little cautious about this, and we're going to talk a little bit about side effects and risks in a little bit. So the neurologic exam, my wife once watched me examine a patient, and she says, "Ooh, you spend all your day playing with people's feet." And since she doesn't have a foot fetish, she wasn't all that excited about this for me. And she made sure that I washed my hands many times before I got home. But the feet are the key to understanding neuropathy, because most neuropathies begin in the feet. So we look for calluses, because a callus means there's a pressure point that shouldn't be there. Obviously, these ulcerations, like here, is a bad sign. And if you had to say what are some of the risks of sensory neuropathy, it's these ulcerations and infections that can cause infection in the bone, and that's where amputations sometimes come in. So anyone with sensory neuropathy, particularly when they say, I don't feel my feet, you need to be incredibly cautious about how you walk. Walking barefoot with people who don't feel things is dangerous, because you can step on things and not be aware of it. And that's some of the things that lead to this. And I'm not trying to give scare tactics here, but it is something to just be aware of. So Dr. Shea talked about large fibers and small fibers. The tuning fork, which seems weird that we use it, but vibration sense is a very good marker of how large fibers are working in someone. So something like B12 deficiency, for instance, has a lot of vibration sense loss. And going along with that is your ability to feel where your toes and your feet are in space. So your balance is very much affected by the large fibers. And so the position when we wiggle your toes up and down and say up or down, we're trying to figure out if you don't know where your toes are going, and particularly if you don't know where your foot's going at the ankle, you're going to have trouble with balance. You're going to have trouble standing in a shower with your eyes closed when you're washing your hair, because you need your eyesight to keep your balance. Your balance is dependent on three things, basically. Your eyesight, your inner ear and the vestibular system of how you, so if you have vertigo, you can see you lose balance, and the feeling of your feet. And if you lose one of them, you can usually manage with the other two. So if you have inability to feel your feet on the floor and you close your eyes, you've now lost two of them. So one was your disease, the feeling in your feet. The other one you artificially did by closing your eyes. But then people lose their balance and fall. So that's why we sometimes have people stand with their feet together and close their eyes, because we want to see what happens in terms of their ability to stand. And these give us clues as to large fiber and small fiber. And different diseases affect one more than the other. So why neurologists hit and scratch? Because it's fun. And we might be a little sadistic. No waterboarding. We don't do any waterboarding, but hitting and scratching we do. So part of this, as Dr. Shea mentioned in one of his cases, patient had a little neuropathy and a lot of spinal cord disease. Spinal cord diseases make your reflexes too brisk. Neuropathy makes your reflexes not brisk enough. You lose your reflexes or they're reduced. So we need to know whether that sensory symptom of yours is from the spinal cord. Remember, all those sensory signals have to go through the spinal cord to be recorded in your brain. And if you mess up your spinal cord, you can have the same symptoms as you have with neuropathy. But the signs, which are brisk reflexes and increased tone in the spinal cord, is you don't see with neuropathy. So that's why we use these stuff. The Babinski sign, where they scratch the bottom of your foot and you think that's torture, is really when the response of the big toe, if it goes up, that's usually a sign of spinal cord and brain problems, central nervous system. If it doesn't do that, then it means the central nervous system may not be affected. So that's what all that's about. Talked about tone. Tone is how stiff you are and how loose you are. Tend to be when you have neuropathy, you have less stiffness and you're loosey-goosey. In central nervous system, you have more spasticity. Atrophy is the shrinking of your muscles. And so when you're shrinking, the muscles are shrinking, it's because you've lost the muscle fibers or they've diminished in size, and that would say that the peripheral nerve is affecting the muscles. You don't see that in spinal cord diseases, you see it in peripheral nerve diseases. So, why do you need that EMG? I heard a sort of thing, torture seems to be a theme in the last few slides. So, it is a very safe test, and the discomfort can be limited, and it is an essential tool for us to understand the disease. As Dr. Shea mentioned, the question of whether the myelin is affected versus the axon is crucial, because if it's demyelinating, we almost always can find the cause. And demyelinating can be due to compression. So, for instance, carpal tunnel syndrome, which is where people wake up with their hand asleep, is a pinched nerve in their wrist, and you see conduction slowing because that pinching affects the insulation to some extent more than the wires or the axons. CIDP is the D in CIDP for chronic inflammatory demyelinating polyneuropathy. The demyelinating is the insulation. That's the myelin that's being disrupted. So if we know it's demyelinating, we can usually find the cause. In inherited neuropathies, there are now about 100 genes that have been found to cause inherited neuropathies. The CMT1 is the demyelinating or Schwann cell cause, and we know we can find the diagnosis in about 98% of those cases. We're only good to about 40% in the axonal cases. So it helps us a lot to know whether your myelin's affected or not. The other thing it tends to do is not only tell us whether the myelin or the axon's affected, but also gives us the distribution. If one nerve is affected, let's say the sensory nerve in the left foot is absent, where the right foot is normal, that gets into this mononeuropathy multiplex picture that Dr. Shea was talking about. So it tells us distribution, it tells us the physiology, is the myelin affected or not, and it can also tell us severity. Now, we don't always know when you come in which nerves we're going to do. Sometimes there's a little bit of a cookbook approach. We do the same thing most of the time for each patient, but you have to then tailor the examination towards the problem of the patients. And you don't always know that until you do it. So that's why it frequently, your doctor is doing the test a lot of the times, because he's trying to help sort out your problem, and it's kind of on-the-job adjustments of what you're going to do on that test. So I talked about the symmetry, localization. It can tell us whether the sensory nerves are involved or just the motor. There are very few neuropathies that are purely motor. There's many more sensory nerve fibers than motor fibers, and most neuropathies are a mix, but some can be purely sensory. There are very few that are purely motor. And most of those actually are disorders of the motor neuron, the cell body, and that's where disorders like motor ALS comes in, because that's a pure motor disorder. It's not really a neuropathy, it's a motor neuronopathy, the cell body itself, not the wires. As an aside, one of the most encouraging things that I've seen in, I can't say how long, has been the ability now to treat one of the inherited motor neuron diseases, spinal muscular atrophy. And there's one treatment out now, and children, babies that were dying in 1 year to 2 years are now being able to stay alive and walk. And there's another treatment that's not out yet that may be even more promising. So part of you, if you have a genetic disorder, the treatment for genetic disorders, which were there were almost zero treatments before, we're now seeing different genetic diseases where treatments are being developed, and very successfully. And this SMA story is truly remarkable. Axons and myelin, I'm going to skip over this a little bit because I think Dr. Shea kind of talked about it. And so similar, I've talked about most neuropathies are axonal. They're more common, less treatable, usually less severe, although they can be, there are forms that are very severe. Axonal neuropathy is the primary affliction in diabetes, but diabetes is a little complicated because the myelin and Schwann cell can be affected on its own as well. And unfortunately, the axonal ones are the ones that are typically the idiopathic. We don't come up with the answer. Demyelinating forms I just mentioned, and these can be very severe, but the nice thing is we have treatments for many of the ones that are inflammatory. And so on the nerve conductions, there are different ways to distinguish between the two, and I'm not going to go into that. So that's the nerve conduction part. Why do they stick needles in me? More fun for the neurologist, I guess, but the fact is it's a direct measure of what your muscles are doing. And the needle EMG is incredibly useful in someone who is weak. If you have a weak muscle, we should be able to tell you whether that problem is in your nerve or in your muscle itself. So do you have a muscle disease or do you have a nerve disease? And that EMG is incredibly useful in terms of distinguishing that. It's a little less useful when someone has pain in a region. It'll tell us whether we see any nerve or muscle damage, but usually we don't see it. The other thing is I can stick needles anywhere where I can't do nerve conductions anywhere. So it's a little hard to do a nerve conduction to a thigh muscle. It's doable, but not easily. But it's easy to put a needle in there. The needles are very thin, they're very safe, doesn't cause infections. And if you're needle phobic, a needle's a needle. There's nothing I can do about it. The nerve conduction part, when the doctor comes in, they'll usually say, we're going to give you a stimulation. What they really are trying to avoid is say, we're giving you an electric shock. Once you feel it, you say, you're giving me a shock, not a stimulation. It's a pretty minor shock. It's very quick. It's pretty mild. But it's a little bit of a surprise until you've had a few of them. And most people hate the first one and kind of get through. After that, it's not too bad. The people who are the worst at nerve conduction patients are electricians. I just show them the little stimulator and they're jumping off the table. They are so sensitized to electric shocks. But sometimes they're a good sport about it. Oh, what did I do there? I have no idea what I did there. So as Dr. Shea said, nerve biopsies, we rarely do them. It's really looking for specific things, which are things that infiltrate the nerves or inflame the nerves, or specific things like amyloid, which is something that infiltrates the nerve. And do you have malignant cells in there? And that comes up very, very rarely. There are some signatures of certain diseases that we see, but most of the time we don't need the nerve biopsy to do that. What we haven't talked about, I don't know, have any of you had a skin biopsy for neuropathy? So there's a few of you here. So the skin biopsy is virtually the same thing a dermatologist would do to examine a spot that you have on your skin. The difference is we stain it for the nerve fibers. And what the C fibers, those unmyelinated nerve fibers, penetrate into the epidermis, and you can count them. It's not the most exact counting, but it's pretty good counting. And we now have normals, so if you have no nerve fibers penetrating the skin, then we say you have a small fiber neuropathy, which is true. Your skin is not there. If you have a reduced number, they might say that's abnormal, and then there's a question, how abnormal is that? If you've only found 4 nerve fibers and normal is 6, does that mean anything? And your doctor needs to kind of interpret that for you. It's a helpful sign for people who have symptoms and they're not sure what's going on. If your skin biopsy is normal in an area that you're having that pain, it probably means it's not coming from a small fiber neuropathy. So I don't know how much time I have left, but 5 minutes. So treatment in 5 minutes. It's a contract. It's a contract between you and your doc. And you and they need to be on the same wavelength of what to expect from your treatment. Gabapentin, Lyrica, Cymbalta do not fix your neuropathy. They might help your nerve pain. And so it's a pain treatment. It is not a neuropathy treatment. So I've had a number of patients, they've been on gabapentin for 10 years. They never had pain. They still don't have pain. And it's not going to treat your neuropathy. The doc needs to explain to you what you should expect in the first few weeks, few months, and what the plan is. So this I do a lot with IVIG because there's a lot of IVIG being given for CIDP, and CIDP can be a difficult diagnosis, and many patients who have that diagnosis probably do not have that disease. When I give anyone IVIG, the majority of them are going to tell me, I have more energy. If it doesn't give them side effects, it has more energy. That's a general effect of immunoglobulins. It's like why your doc 50 years ago used to give you gamma globulin shots if you were tired. it has some effect on energy, which is nonspecific, but it's not treating your neuropathy. Your CIDP will continue to be CIDP even though you have more energy. Now, if it works on the CIDP, and it's an excellent treatment for CIDP, then you're going to actually see your strength getting better. And so what I do, and I know Dr. Shea does this as well, is that we have things we look for. I measure your grip strength. I give you surveys of how you're functioning. I actually get people to get up from a chair and walk a distance and measure the time. So when you come back in 3 months, we say, oh, I have more energy, but I am not doing any better with my grip, my function, or getting up or walking. We have to think about why is that treatment not doing what we really wanted to do, even though you feel better. So that gets into a bit of an issue because you might say, I still want that treatment because I feel a little bit more energy. It's a lot of IVs, and there are some risks with IVIG, so you have to be careful about that. Plus, I'm trying to get you where your disease is under control, and it may not be doing that either because it's the wrong diagnosis or the wrong treatment. And for me, if I think you have CIDP and I give you IVIG and it's not working, when I expect it to work in 75 to 80% of the people, I first question my diagnosis, and then I think about whether I need to change treatments or and sometimes that change could be giving more IVIG or switching to a different treatment. So this is a big one. This is a California thing. I moved from Michigan and I've worked on the East Coast. Doc, I don't want any medicines. Fix me with no medicines. And the question is, why? Well, there are side effects. Well, side effects and risks are not the same thing. A risk is I give you the medicine and you're going to die, okay? You don't want that medicine, okay? Okay. Now, not everyone's going to die, but say the risk is 10%. That's still a huge risk if you're going to be seriously ill and in the hospital. That's a risk. If you had cancer and you're going to potentially die of the cancer, you might take that risk. For some of our neuropathies, you might not want to take that risk. A side effect is I give you the medicine and it makes me too sleepy. Okay, you stop the medicine and we'll try something else. That's a side effect. And the potential risks and side effects versus the benefits, everyone needs to weigh. The other thing is, I don't want medicine, I'm going to use natural methods. So they go to their natural health store and they get all kinds of stuff. Sorry, that's still medicine. It's just not something that you prescribe. You still need to know what's the benefit, and you need to have some very clear understanding. Otherwise, you're going to spend a lot of money forever taking stuff that's not really doing what it needs to do. So think about that. And I think I'm running out of time. And I think I'm going to leave you there, and I'm happy to talk about other things in the future. So thank you very much.